Hello. I wished I had the opportunity to be with you in Taiwan right now. Still, I'm happy to give this presentation in a virtual way. The title of this presentation is Patient-Reported Outcomes of Adults with Congenital Heart Disease Across the World. This is a scene that you are familiar with, a patient-physician encounter. And quite often, clinicians do have the chance to give good news to the patients. For instance, congratulations, the tests were negative, everything is perfectly all right. However, this kind of information does not always concur with how patients feel. Indeed, sometimes patients, irrespective of the negative tests, may think, my whole life is affected. I cannot eat, exercise or sleep. And this discordance between what clinicians and patients think is not always surprising. And this has to do with the fact that clinicians quite often look at clinical outcomes, such as were there any complications, what did imaging show, what do we learn from the biomarkers, and is the patient still alive? However, there is also another part of the spectrum, and this is the part that has to do with patient-reported outcomes. What about quality of life? Have symptoms and functional status improved? Do patients adhere to the treatment? What are their goals and what are the experiences with healthcare? This kind of patient-reported outcomes is very important if you want to have a comprehensive view on patient outcomes. As you can see here, one particular component or one particular aspect of patient-reported outcomes is quality of life. And a few years ago, there was an interesting article that was published. It was a meta-analysis on quality of life in adults with congenital heart disease. And the main finding of this meta-analysis was the results from some countries, most notably the Netherlands and Switzerland, seem to be better compared with the US and Canada, while the expected random fluctuation in results was found for the remaining countries. Why is this interesting? Well, on one hand, clearly there were some differences that were found across the different studies, but the question is this because there are real differences between the quality of life of the patients, or is this due to methodological differences across the study? And this inspired us to conduct the APPROACH-IS. APPROACH-IS stands for Assessment of Patterns of Patient-Reported Outcomes in Adults with Congenital Heart Disease International Study. This was an international study, indeed, conducted in 24 centers from 15 countries in 5 continents. And we included over 4,000 patients with a slightly high representation of females, and the median age of the patients was 32 years. It was a study on patient-reported outcomes, so we used questionnaires. And the questionnaires pertained to the self-reported health, psychosocial functioning, behavioral outcomes, and quality of life. Overall, more than 30 articles have been published on the results of APPROACH-IS. But interesting for you is that earlier this year we wrote a kind of a summary article combining all the different results, describing all the different results of the different papers in APPROACH-IS. So if you go to that particular paper, you have a snapshot of what we learned in APPROACH-IS. The first goal of APPROACH-IS was to look at differences in patient-reported outcomes of adults with congenital heart disease who are living in different areas of the world. And this heat map is illustrating the findings of the study. And as you can see here, we could rank order the different countries according to their overall patient-reported outcome scores. And you see here that Patients from Switzerland, Sweden, the Netherlands are scoring pretty high, whereas patients from Japan, France and India are scoring rather low. But even more important is also to look at differences across the patient-reported outcomes within countries. For instance, when you look at Taiwan, Taiwan is doing very good in terms of anxiety, but not so good in terms of depression. Or another example, Japan, if you see the results of the patients on physical functioning and anxiety in Japan, is pretty good, but not as much in quality of life. So comparing the different countries is something you can do with this heat map, but also looking at the different outcomes in a country. Another heat map that we developed was looking at health behaviors. And as you can see here, indeed, once again, certain behaviors are very prevalent in some countries or less prevalent in another country. And let's have another look at Taiwan here. When it comes to binge drinking, smoking cigarettes, drug use, Taiwan is doing very good. When it comes to sport participation, that's the place where you have room for improvement. When you look at Japan, it is a bit similar in terms of recreational drug use, very good, very low prevalence, but not as much in participation of sports. So this kind of heat maps is giving relevant information in this matter. The second goal of Approach IS was, how can we understand these differences? How can we explain these differences? And for that purpose, we have also summarized all the predictors for patient-reported outcomes that we have investigated and where we found significant associations. It is summarized in this figure, and let's have a look at the different domains. The first domain, the medical domain, there we found that patient-reported outcomes are associated with having an ICD, atrial arrhythmias, a worse New York Heart Association class, and the different heart defects. And when it comes to different heart defects, have a look at this figure. Here you can see that, not surprisingly, patients with cyanotic heart disease or Eisenmenger syndrome are doing worse in terms of physical component summary, physical functioning here, but this is true for all the patient-reported outcomes that we have investigated. And it was followed by patients with univentricular heart and pulmonary atresia. When you look at the best scores, you can see that patients with coarctation of the aorta and isolated aortic valve disease, they are scoring best. And also here, this is true for all the patient-reported outcomes investigated in Approach IS. Looking at demographic predictors, we found significant associations with age and sex. Men had better perceived health, less anxiety, but they presented with more health risk behaviors compared to their female counterparts. And when it comes to age and the relationship with patient-reported outcomes, we see overall a negative relationship, and this is an example of quality of life. Quality of life is lower when people are getting older. However, you should not think that this is a linear relationship, as you can see here. As you can see in the green and the yellow line, people with moderate or mild heart defects, they do not have a lot of evolution in the quality of life over ages. However, people with complex heart disease, they are doing pretty good in their quality of life until the early 30s, and then a decline is starting. So we need to be aware that the relationship between patient-reported outcomes and age is not necessarily a linear relationship. Behavioral predictors. We found physical activities, cannabis use and smoking as predictors for patient-reported outcomes. Indeed, sport participation was associated with better physical functioning, and the explained variance was 8%, which is not negligible. And also sport participation was associated with depressive symptoms with an odds ratio of 0.62. When it comes to cannabis use and smoking, there were significant relationships between the use and the outcomes. However, when you look at smoking and cannabis separately in relationship to the outcomes, the effect was pretty small. It was not the case for people who were co-using. So it is very important to know those who are smoking and are using cannabis, they do have a substantial effect on their patient-reported outcomes. The following domain are psychological factors. And here you see self-efficacy, sense of coherence, illness identity, and illness perception. This is an incredibly important domain for the following reason. The relationship between illness perception and physical functioning, mental functioning, self-rated health, anxiety, depression, and quality of life was found. And look at the explained variance. This ranges from 16 to 27%. This is a large part of the variance in the outcomes that is explained by these factors of illness perceptions. Also, the other psychological factors, such as self-efficacy, sense of coherence, illness perception, the explained variance here ranges also from 9 to 17%. So this means that if you really want to improve the patient-reported outcomes, make sure that you target on the psychological factors, because doing so you have the strongest potential effect. The fifth domain of predictors was the social domain. And here you could see that we distinguish between individual factors, factors related to a person, to the patient, or contextual factors, the context where a person is living in. Quite often these are country-related factors. And the individual factors are indicated here in the light pink, being employment status, educational level, being single, and being religious or spiritual. And when it comes to country-specific factors, we found relationships with gross domestic product, human development index, dimensions of national culture, religious versus secular countries, human resources in healthcare, national expenditures in healthcare, and healthcare system performance. I have to admit that the shared variance of these contextual factors was very small. This means that this is not strongly contributed to the patient-reported outcomes, although there is a significant relationship that we have found. As I said in the beginning, these are the results, these are the findings of APPROACH-IS. And we have learned a lot from this study. But the more you learn, the more new questions emerge. And that is the reason why we developed APPROACH-IS 2. That is a study that currently is in progress. And this is a study where more than 60 centers from more than 30 countries are participating. You can imagine that this gives a new set of data where we can learn a lot on patient-reported outcomes in adults with congenital heart disease. Let me come to the conclusions of this presentation. Some take-home messages. First, patient-reported outcomes provide complementary information in addition to clinical outcomes. International variation in patient-reported outcomes is confirmed. Indeed, we expected that, but now with a common, uniform methodology, we were able to confirm this. Individual and contextual predictors for patient-reported outcomes have been identified. Some are stronger than the others, and therefore it is important to look at what are the factors that have the strongest relationship with patient-reported outcomes. And these are the psychological predictors. They explain most of the variance and they are actionable. So this means if you really want to improve the patient-reported outcomes of your patients, never neglect the psychological factors, because if you impact on them, if you improve them indirectly, you are able to improve the outcomes of your patients. Thank you so much.